Hi there, welcome back at M2 Meets. And in this month of October and November, we're going to talk about pivotal papers which changed the approach EUSOBI is looking at breast cancer screening. And we published a paper on that where we basically used extremely strong evidence from two studies which changed our perspective, how we recommend breast cancer screening programs should be changed in the future. And one of the most important studies we have seen in the last decade has been the DANCE study. And I've got the privilege to talk to the PI of the study, Professor Carla van Gils from Utrecht, who is one of the leading epidemiologists worldwide, and she was the leader of the study. So hi, Carla, thanks very much for being with us today again for a little longer take of the interview. Let's talk a little bit in detail on the study. So in a nutshell, what are the key messages of your study from a PI perspective and from a perspective not of a breast radiologist, but of an epidemiologist per training?
The key finding of the DANCE trial is that with MRI, we can detect much more breast cancer in women with extremely dense breasts, even after they have a negative mammography. And what's more to that, we also know that it detects clinically relevant breast cancer because we saw that the interval cancer rate after an MRI strongly comes down compared to women who only undergo mammography screening. And the reason that the evidence is so strong is that we could confirm this in a very large randomized controlled trial with more than 40,000 women included, where we were able to follow up the women and not only to look at what we detect extra, but also to follow up and see what happens with the interval cancer rate.
That's awesome. I think there are 2 points where we should a little bit focus on in our chat. Thanks again for joining us for that in the next minute. So first of all, interval, what is that? Interval cancer detection and reduction, and a randomized controlled trial, because these are very important, very difficult to set up parameters. So let's talk a little bit about what is interval cancer reduction and the degree how you measured it. What's your methodological approach and how do you interpret the results?
Yeah. So we choose the interval cancer rate as the primary outcome of the DANCE trial, and the interval cancer rate is the amount of cancers that occur in between screening rounds. And we did that because a reduction in that would be first prerequisite or a surrogate for later breast cancer mortality reduction. If you would look at breast cancer mortality reduction, you would need a trial that is very much longer and very much bigger, and it's unlikely that that is feasible under the current circumstances. And to be able to look at interval cancer as an outcome, you also need a randomized control arm. So many of the studies that are out there on supplemental screening, they have just one group of women who gets one method, mammography, and an MRI, and then you see what you detect extra. But you can never answer the question whether one would lead to less interval cancers than the others, because for that you need parallel groups. So one group receiving both and one group receiving only the mammography. And you have to do that in a randomized fashion because you want to make sure that it is sort of a similar group of women and not that the group who receives MRI has a much higher breast cancer risk, for example, than the group who does not receive the MRI. So that's why we set up the trial in this way. And that's what makes the evidence strong. The strongest you can get, I think, in a reasonable time frame.
These are extremely important points, and thank you again for making this so crystal clear. So the interval cancer detection rate is super important. We are simply not able to measure in a study the breast cancer mortality as a direct marker, so we need surrogates, and this is one of the best we can get, and still needing a tremendously large number of patients. So 40,000, 50,000 is a huge numbers. This is amazing. This is number one of your answer. I just try to recap because it's so dense. What you're talking about, you're an epidemiologist. This is digest sometimes hard for the breast images. And the second answer was the randomized control trial. I think this also has to be stressed. We have a control group, so we can really compare to something. Talking about comparison, reading the number, the interval cancer detection rate, and the lowering in each group, we have this 5 versus 2.5 in the key results. And this is, I'm reading it frankly, a little bit underestimating the true power of breast MR, because as far as I recall, many patients didn't go for MR for reasons which we don't know. So what is your approach to interpret this number? 2.5, 6, 8, etc.
True. You have, so first of all, the women were randomized by an invitation to MRI. So only if you were in the invitation group, you would actually be offered the MRI. So the other women in the control group, they were not offered the MRI. And what can happen then is, of course, that women do not accept the invitation. And that's what happened. So we saw that a little less than 60% of the women wanted to undergo MRI. But as it is a randomized trial, you have to keep the randomization intact to know that the groups are comparable. Because if the 60% of women that accept the MRI have much higher breast cancer risk or higher risk of an interval cancer than the 40% that did not accept the MRI, you would get a biased result. So it's comparable to drug trials. It's intention to treat or intention to screen, whatever you like. So that is our primary analysis. But what we also saw is that, and that is luckily, so that's why we can interpret it better, is that the group of women who did not want to undergo MRI have exactly the same interval cancer rate, or almost exactly the same interval cancer rate as the women in the control arm. So there does not seem to be a strong selection in terms of a higher or lower risk of interval cancer in the group of women who accepted MRI. So therefore, we also feel confident to really look at the group of women who received the MRI, and then we see an interval cancer rate of 0.8 per 1,000 compared to approximately 5 per 1,000. So then you see that the effect is much bigger.
And that's a beautiful remark, which everyone who reads the study can read, but I think it's a very important point that receiving the envelope basically for the invitation and not opening it basically leaves you at the same risk as in the control group, right? So the people who did not respond to the MR invitation, which are still in this overall average number, have the same risk of interval cancers as the control group. I think this is super important and tells really how strong and representative the data are. Yeah. So what would be your personal feeling? Obviously, you are sort of bound to the study design, which I totally understand. But looking at the numbers, having played, I think, a lot with the numbers, what do you think would be a realistic, direction where you could see interval cancer reduction rate could go with MR comparing to the control group? Because the number, which is 2.5, is diluted, obviously, by the non-responders, by the non-coming to MR people. Exactly,
but because the non-responders turned out not to be a very selective group, I think the 0.8 per 1,000 is quite realistic.
Which is, I think, very important and has to be stressed, and this is a tremendous difference. Yeah. So now we talked, and you explained to me as a simple-minded breast radiologist why randomized control studies are so important, particularly in this sort of evidence. We discussed interval cancers, why they are important, why it's the measure to measure in this sort of design. and why the reduction in your study has been really tremendous thanks to MR. Then let's close the interpretation book of the data because we only have a few minutes left. So thank you for your time again. But let's open the window into the future. So what you're going to do with your group? Where are you leading your research, and what are the next steps, and what are your expectations in the next years to come?
So within the trial, there's more to find out. So what we also did is, and that has already been published, is a cost effectiveness analysis, so that you can see that MRI every 3 or 4 years is cost effective. At the same time, we are trying to work on reducing false positive diagnosis, for example, with AI methods. Looking further to the future, I think we may be even better able to predict who is at the highest risk of a cancer that is diagnosed too late, because now we use the density, but we also know that there's much more information in mammography and also in MRI when you had one already, that we can predict the risk better. So I think it's going to be even more personalized than it is now. I mean, this is one of the first trials where we actually see personalized screening based on more than age. So we know that it can work, but it can be even a finer prediction. And so I think that's where we're going to see more in the future, and that's also what we are working on, and perhaps also to provide less screening for the women with the lowest risk.
Okay, this is basically all directing to strengthen the approach of personalized screening, to adapt to tailor screening methods by women who are more at risk, at higher risk, and you can use imaging to stratify these, and which I think super important and super interesting to provide a less screening in people who are at very low risk. This is beautiful, yeah. And a final question, Carla. It was really a true privilege to talk to you, because this study is really changing our role of how we approach screening. And it's the beginning, not the end, as you said. It's just the first step to personalized screening, which is still a far way to go. But your perspective is important. First of all, the quality of your research per se, but you have got a different perspective. I'm a breast imager, and we at EUSOBI are breast imagers. So is there any particular advice you say, how you as an epidemiologist, having conducted as a PI one of the largest trials on breast imaging in the last decade, is there any take home or homework we have to do to sort of make this happen, make this reality, which we would like to share with our audience? Because you are looking different at what we do. On one side, you know us very well. On the other side, you're an epidemiologist. You're not doing breast imaging.
Yeah. I think for any of the imaging studies that are being done in the field of breast cancer screening, it's extremely important to also because we have to really balance well the harms and the benefit of screening. It's really important to look at all aspects and to use the right design and to go for large studies and to see what they look like at several years of follow-up before we immediately step into something. I think that is extremely important, to really collect hard evidence to lead the guidelines, so to speak, and not jump onto every new technique before we have the evidence that it's useful.
Thank you very much. A wonderful final statement by you. So obviously we will face problems with every new method, you name it. But this is an extremely long process with every method, and don't sort of jump on the alternative method once it's getting tough, because it's going to be tough with any method. And the evidence has to be the toughest at the end to provide the best care to our patients. So thank you very much, Carla, for sharing your time today. We learned a lot. We learned about study design. We learned about your personal commitment, involvement as a PI. We learned about the perspective. And we also received take-home lessons, how to deal with these kind of studies and new approaches. Thank you very much, Professor Carla van Gils, who is still the PI, the leading researcher of the DENSE study. And thanks you all home for watching us for the long edition of this interview. Stay tuned, take care, and make sure to follow us on our channels, which is YouTube, Instagram, Facebook, Twitter, and soon they're going to be also LinkedIn. Thank you very much and have a good one. Bye.